Good morning, everybody. Welcome to Public Services Committee. This is, I should say it's Monday, the 14th of October, 2024. It is just gone 10 a.m. I'd like to welcome all the committee. Before we do so, we've got Lloyd and Rachel here as our guests today. I think it's probably worthy of us just to introduce ourselves. So I'm going to ask the people in this room, and then we're going to go through to the people online. So, Marion, if you'd like to introduce yourself.
Yeah, good morning. Marion Howells, I'm a ward councillor for Llanbarrick and Usk, so this area here. Thanks.
Ian.
Yeah, and I'm Ian Chandler. I'm the Cabinet Member for Social Care, Safeguarding and Accessible Health Services. So I'm not actually a member of this Scrutiny Committee, but I thought I would join in because I'm interested in what you've got to say. Thanks.
Okay, and then we've got I'm going to go on what's on my screen. Hazel, we've even got Francis, I should say.
Good morning, Frances Taylor, Mega, Councillor and member of the Scrutiny Committee.
Councillor Bond.
Good morning, Jill Bond. I represent West End on Town Council and County Council. Okay. Thank you.
And then we've got Councillor Garrett.
Steve Garrett, I'm the Town Councillor and County Councillor for Overmono.
Okay, we've got Councillor Rourke.
Monmouth.
Thank you, Steve. Councillor Rourke.
I'm Councillor Dale Rook, representing Chepstow Castle and Larkfield wards, member of this committee.
Yeah, and welcome, Louise, as well. You are substituting today, aren't you? If you'd just like to introduce yourself.
Yeah, good morning. Councillor Louise Brown, Shire Newton ward, substituting for Councillor Tony Kerr.
Okay, and then we've got some other guests. So we've got Councillor Strong.
Hi, Pete Strong, councillor representing Roggett ward, just here really as an observer today.
Okay, and we've got. Sorry, I do apologise, Malcolm. I've left you out, Malcolm.
That's okay, Councillor Malcolm Lane, representing Mardy, and a member of this committee. Thank you.
Yeah. Okay, Malcolm. I'm just got an observation here. Are you driving?
Yeah, I'm driving. I'm actually off to conduct a funeral, but I'm listening intently.
Let me just wait a minute. 1 second. Yeah, okay. Malcolm, I'm going to just say, my advice to you, because I'm not sure where you are, obviously you've got important business this morning, would be to possibly pull over and then take in if you can, because we're obviously concerned about the welfare and other people. Thank you. Okay, brilliant. If you just, just turn your camera off maybe. And then, okay, sorry, I've lost my train of thought. And then Councillor Bryn. You're on mute, Councillor Bryn, sorry.
I'm sorry, Councillor Bryn, Washington ward member, not a member of this committee, just as an observer today. Thank you for letting me listen in.
So what I've said is to all the observers, I mean, effectively, you've come into this meeting. If you've got any specific questions, this goes for the Cabinet member, who will probably Bag's first question, because of his kudos and position. I'm joking entirely, then I will bring them in. And I said that really to Peter as well. So, it's an open meeting. There are guests. I just want to remind everybody, whilst we can grill them, they don't have to come here, okay? So a bit of gentle, rough play is okay, but properly laying into them is not acceptable, despite some of the frustrations. Right, so first on the agenda, apologies for absence. We've got Penny. Unfortunately, Penny is not with us today, and we'd like to wish her well. I believe she's currently having an operation for a gallbladder. So I'm sure elected members and guests and everybody, in this meeting would like to wish Penny, the best of health and going forward. So we will obviously communicate that to Penny via email. So Penny, if you're watching this in retrospect, we wish you well. Right, moving on, declarations of interest. I don't believe there are any. Hazel? And then the public open forum we don't have any members of the public here, so I'll move straight into dentistry services. So what I'm going to do, I'm just going to, obviously you've come here before, Lloyd, haven't you? and Rachel, yeah. And, you know, we've covered some of the points before. No doubt in this meeting, members will want to go back over them. But effectively, I'm going to open up the floor so you can come back and then explain to us what, you know, give us some updates about where we are. Obviously, you made notes of, you know, our concerns last time, so the floor is yours. Yeah, press it down.
Okay, thank you very much, Chair, and thanks, members, for the invite today. So what I'm going to do, first of all, is just cover off a bit of an update in terms of where we are, try and pick up some of the additional questions, concerns that were raised in the previous closed meeting and session, and hopefully be able to then answer any additional questions that come from the committee. So first of all, just to sort of reflect back in terms of where we are currently with NHS dentistry. So it is unfortunately a challenging situation for NHS dentistry across the whole of the UK, and particularly, as we've noted, within Wales. It has been really an impact that's been ongoing since COVID-19, and that was broadly as a result of the infection prevention control measures that were required for dental practitioners to work safely and to keep their patients safe at that time. So there has been significant sustainability challenges as well, and I've talked previously about some of the workforce and recruitment issues that are present within the dental profession. But as a health board, as an Aaron Bevan University Health Board, we are committed to trying to address those sustainability challenges and support dental practitioners as much as we can. And we have actually developed and got a sustainability board that is in place at present with a series of actions and an action plan to try and help support the dental profession as well as our other independent contractor professions of general practice, pharmacies and opticians. So for those who may not or may not be aware, so, the dental provision within an Aaron Bevan is split into two, so general dental services and also community dental services. So I'll talk first of all about general dental services and then touch on some of the work that the community dental services provided by an Aaron Bevan University Health Board provide. So general dental services, so we commission this service through independent contractors, as does every other part of Wales, and this is under the National Health Service GDS contractual regulations that were founded in 2006. So across you know, the 600,000 population that we serve within an Aaron Bevan, there are 76 general dental practitioner contracts, and as I said, they're responsible for providing that general dental care to their patients, and this has been in place since sort of 2006 when that contract was founded. Now, it is important, and I've made this case previously, to flag that patients aren't registered with a dentist like you would be for a GP practice, for example, and it forms as part of a responsibility of the patient to ensure that they do have that regular and ongoing dental care with a practice that they have for the NHS, and that's a nationally agreed Welsh Government contract that we support and deliver. So within Monmouth, because obviously this is a key focus for this committee, we have now got 10 NHS general dental contracts that operate across 9 different sites, and they are split across 2 different types of contracts. So in 2022, there was a new contract brought to light, which was called contractual reform, and that dental practitioners had the option to stay with the previous contract, which is called UDA, or Units of Dental Activity, or move into the contractual reform element. So we did have a split, and we've had increased numbers moving into the contractual reform in recent months. But what we do have, as I said, is those 10 GDS contracts operating out of 9 sites within Monmouth. So we have had some challenges, as I've already mentioned and touched upon. So what those challenges do cover as well is contract resignations. So within the last probably 3 years, we've been monitoring contract terminations as and when they have arisen. So across an Aaron Bevan, we had 4 contract resignations in 2022, and 1 was in Monmouthshire. We had 2 contract resignations in 23-24, and none of those were in Monmouthshire. And thus far this year, there have been 6 contract resignations, 4 of which have been in Monmouthshire. Now, the Health Board is very pleased, actually, that we've been able to successfully re-provide all of the NHS dental care for those contract resignations, and these have meant that we've been able to re-provide that within the Monmouthshire Borough as well. We are limited in terms of who is able to provide those, in terms of contractors being able to come forward to accept new and additional patients and contractors. But what we have seen is actually a brand new provider coming in and setting up within the Monmouthshire area. So we are pleased within that. So I talked previously as well to members here that where those 4 contract resignations were. So it was Bridges Dental in Caldecott, it was Trevennwy Dental within Monmouthshire, and just on the Trevennwy site they had 2 NHS contracts, so they still are providing NHS services, but their additional NHS contract is what was terminated or now is being re-provided. There was Thrive Dental in Mega, and then Beaufort Park Dental in Chepstow. So the last time that we spoke, we advised that we were still undertaking the procurement exercise for the patients who were accessing care at Beaufort Park Dental. And as I've just mentioned in my previous information, we have now successfully re-provided that across a number of different providers. So 7 Dental, who are located in Chepstow, will be taking on additional patients from this cohort, as well as St Julian's Dental Practice, which is within the Newport area, and 168 Dental, again, which is in the Newport area, and it covers off the list size that Beaufort Park had, that also had residents from the Newport area that were accessing their care within Beaufort Park. So we, as a health board, are really committed to try and ensure that we improve and increase the access to dental services. We are limited in terms of our financial ability to do so, as we have an allocation that is devolved to us from Welsh Government. But where we are looking as this health board is what's known as a Marmot region, so we have high levels of health inequalities across all of the Narrow and Bevan Health Board, and we are investing in 2 sites. So the Tredegar Health and Wellbeing Centre and Development has had an investment of 300,000, and also we are planning further investment as part of the Newport East Health and Wellbeing Development, or 19 Hills as it will be called, which will have an investment of 286,000. In terms of where we are for community dental service, so that other element. So for those who don't know the community dental services, these really provide dental care for vulnerable children and adults, and we deliver that from 11 dental clinics as a core service, and it also includes services and programs for children in special schools and units, looked after children, adults with learning disabilities, people who are homeless, those who misuse substances, asylum seekers and refugees, as well as other vulnerable groups. And really it's a oral health promotion team that is built within this service as well, and what that does is, again, it supports those vulnerable adults. So there are 2 sort of schemes that sit within this, something called Gwenam Byth. So this is a national oral improvement programme, and as I say, it's delivered by our community dental services. And broadly, what it does is provides support and hygiene of oral health for people who are living in care homes, and it is delivered in partnership with the care and nursing home staff, and we ensure that wider health professionals are involved within that as well. So at present, and I haven't got the breakdown for Monmouthshire currently, but we have had 87 homes across Gwent who've been involved since March of 2024, and 96% of homes have undertaken within this scheme at present. And what that translates to really is that we've been able to deliver over 300 sessions of training, and over 500 care home staff are now being able to have that training and support their residents in terms of good oral and preventative oral health care. The second element, which is associated with children programme, so it's called the Design to Smile programme. So again, it's a national oral health improvement programme and delivered by our community dental services. So there are two elements associated with it. So one is toothbrushing and support for toothbrushing activity, and the second is fluoride varnish. So both of these are key preventative elements for oral and tooth decay. We again deliver these elements in partnership with primary schools and also with preschool support staff. And I have got the Monmouthshire breakdown for this information. So in terms of the toothbrushing activity for primary schools, there are 12 eligible settings within Monmouthshire. 10 of those have agreed to take part. So 2 obviously have either refused or withdrawn during the time period we've provided. And what we have done is provided over 770 children with those preventative measures and support. And then same for fluoride activity. So this is the adding of fluoride and support in terms of varnishing to teeth, and that's a key preventative measure. Again, there's 11 eligible settings, and there's of those 10 are taking part. Again, 1 is withdrawn, and what we have had is over 465 children had their first application, and because we're in the second phase of that now, because it's year by year, 130 of those 400 have had their second application. So we are progressing with that. So I talked previously that the dental contracts, as I said, which are nationally agreed and commissioned with Welsh Government, the British Dental Association and the NHS, have really driven more of a focus now towards a preventative agenda, so a needs-based approach in terms of managing patients' oral health, as opposed to routine follow-up for those, no matter what your oral health need is. As a result, what we have found, as I said, that we've had to put on additional urgent care provision. So I was looking at our recent figures, and we have been, as I said, increased how we can add urgent dental care for those patients within this area, so within Monmouthshire. And I've been looking at our figures. So although we do provide additional appointments available, we aren't having the level of uptake that we would see. So within Monmouthshire, approximately 40% of those appointments are going unfilled for urgent care, and we are reviewing them on a regular basis to ensure that we've got the numbers right, but also that the communication of access to them is correct as well. So what we do have is a dental helpline number that people can contact and support, and following feedback from this committee in a closed session, we have adjusted how to access that on the comms website, so people should be able to access that more easily, and we are including that in any communication to patients when and if there is a change in dental provision within their area. Additionally, when we spoke previously, there was questions around whether there should be the development of a sort of a central access point or a waiting list. Because at present, dentists are holding waiting lists on individual practice-based levels. Since we last spoke, Welsh Government and the Digital Health and Care Wales, so DHCW, have agreed to start the development of a dental access portal. It has moved very quickly, so Powys initially were the pilot site over an 8-week period, and the rollout now is planned in this health board for the 20th of November. So what this should do then is be able to, one, provide a centralised element of understanding demand within the area, but it will also help us then as a health board and Welsh Government understand the level of demand in terms of understanding what level of additional investment may be required into the dental service to make sure that we meet the demand. I'm going to stop there just for a second. I know I've probably covered off a fair bit of detail, and I know that we've discussed some of this previously, so I'm not intended to go into a lot of the detail. I'm going to see if Rachel wants to bring anything in addition, so not at present. So I'll stop and I guess open to questions, Chair.
Yeah, brilliant. Thanks, Lloyd. That's a fair summary, and I think some of the issues you've already covered on for the last meeting. Some of the new members won't know that, so that's interesting. But I haven't seen, I'm quite surprised at this point, they were also eager in pre-meeting to kind of have lots of questions, and now they've kind of, I don't know, they've all had a cup of coffee as well. Dale's having a massive cup of coffee in front of him. but there's no questions. Where are the questions? Oh, there they go. Jill was first, then Dale. Jill, if you wouldn't mind.
Okay, sorry, there was no chat function, so that's why, sorry. Sorry, no function in the chat, sorry. Thank you very much for the update, Lloyd, really good. Really want to understand the change in policy or the change of approach, because from what I picked up you said was it's up to the patient now to follow up rather than them get automatic 6-monthly checkups or whatever, or preventative dentistry as used to be. So the whole policy or concept has changed from the NHS, or at least an Iron Bevan Unitary Health Board, giving that preventative, but now adults need to go in and follow up for themselves. Is that, did I understand that correctly? Really, really commend and really think it's wonderful that you're doing all the preventative work for the young people, children, young people, and people with limb disabilities and the older people. Wonder how far that's going. Is it extensive across Monmouthshire? You mentioned something like 400 or something. I guess there's more than 400 children around, but the Design to Smile, and also, yes, so really as a concept change from the old model of people going every 6 months, and this is that the whole reason why we've seen a difference in the provision, because it and if that had been explained more, perhaps people would understand, and the reasons why it's changing. But it just felt like it was a change, and I thought, sugar, it's all changing what we're going to do, rather than if we'd been shared that the whole concept's changing and this is a better model, then perhaps we wouldn't have had the difficulties in understanding. Thank you.
Thank you, Jill.
So first of all, thank you for your question, Jill. So I'll try and pick up the two bits. I'll tackle the first point first, if that's okay. So in terms of the health board, what we are tasked to do as a health board is to implement the nationally agreed contract. So we wouldn't be doing anything different to other health boards in terms of policy changes, etc. We implement, as I said, what the national approach has been. So in terms of the shift change in approach, that has been sort of the ethos of the contract reform that started in 2022. So historically, dental practices followed a contract which was called units of dental activity, and effectively that was that routine element of you'd be seen every 6 months no matter what happened, and you'd have your treatment as required. And what the movement to is what's known as contract reform contracts, and what that does, it undertakes something called ACORN, which is an assessment of clinical oral risk and needs. So effectively now there's a risk-based assessment that's undertaken, which means that more of the right people can be seen at the right time, as opposed to routine elements for those who may or may not need that level of care on a regular basis. Just in terms of the responsibility on the public or population, so it has always been the case that patients are not registered with dental practices, and it's been the responsibility as well for the patient to ensure that they have that regular attendance at practice to receive ongoing dental care. But it's probably been easier in those previous years because it's been that mentality of 6 months, I need my review and then follow up. And now what we're changing to now is that you'll have a time period that is appropriate to your oral health needs for that review and follow up. From our perspective, what, as I said, we've been seeing in terms of the movement is that this is not a once-off and short-term approach. So we have had practices, and we continue to have practices that offer one or the other. So in 2023-24, so last financial year, what we had within Monmouthshire was 5 practices who were operating under the new contract reform, which is this preventative measure, and then 8 under taking the units of dental activity, so the more historic element. Where we are now in 2024-25 is that we have 10 contract reform practices with 3 units of dental activity. So we've seen more practices move to this new way of working, and as a result, I will completely agree with you, Jill, that there is and should be a greater communication campaign nationally from Welsh Government, and we do as much as we can as a health board. We are challenged as a health board because at present we still have a split of UDA versus contract reform, but there is ongoing negotiations at present for the next contractual elements, and we are expecting the movement to be more towards the wider spread elements of the contractual reform with a focus on prevention. In terms of children, so as I said, for us, the Design to Smile team, the key thing of that services is improving the oral health in younger people. So it is broken down into toothbrushing activity for primary schools and then preschools, and there is a focus on those areas of greatest need. So under the Welsh Index of Deprivation 1, 2 or 3, so the higher the level, the greater the need for the service to be provided within that area. So as I said, in terms of the eligible settings, so in Monmouthshire there are 12 eligible primary schools. 10 of those have agreed to take part in that programme. So each school, and obviously they work with the local authorities and partnership to ensure that we have access to those schools, but we can't drive that further into those other schools. That is a decision for the school to be made in terms of the capacity, because equally it's an additional element of time that's taken away from other activities. So within the primary school, there are 888 children who are eligible, and at present 770 of those have or are undertaking the toothbrushing activity. I would note that these children do need to be consented to undertake this. So there are some families who do not wish to consent to undertake that, and we work with those families then to understand some of the reasoning and how we can support if we can do so. In terms of the preschool element, so the preschool element is where I referenced that there are 16 preschool settings, 12 are taking place and 4 of those have others have refused. So what that is it's 260 eligible children, and of those 260 eligible children, 250 have been consented and are receiving that support. The 400 number you quoted, Jill, was in regards to fluoride varnish. So fluoride varnish activity, so that occurs in 11 eligible settings, so it's a different sort of age cohort. There are 10 of those 11 who have agreed to take part. So the eligible numbers would be 1,029 children who would be eligible. Of that, 737 have given consent to proceed. So we've, as I said, been able to provide the 465 at present to the first application, but because it's a yearly rolling programme, the figures sometimes skew over the 2-year period. So we're confident that we are capturing as many of those patients as we can do.
Thank you very much, Luke. Can I just check, Chair, please? Is that in Monmouthshire you're quoting all these numbers?
Sorry.
Thank you.
Monmouthshire.
Thank you.
Is that okay, Jill? You've had a fairly comprehensive answer there, some interesting stats. I'm going to ask you this once. Have you got any supplementaries?
Myself? No, only that we discussed the ACORN before. The ACORN situation before was why so many NHS were going out of business, because of the need to assess how much dental activity someone might need, and then if that changes, then the dentist has to fund that. That's one of the difficulties they said that they had. Is that still the reason why some of our dentists have been going out of business?
Good.
So just for clarity, I guess those practices haven't gone out of business, but they've stopped providing NHS services.
That's what I meant. Sorry. Yes.
So they've made obviously a business decision in terms of their models and in terms of providing alternative services as an independent contractor, and as they can do so. As I said, there is a mixed bag here because, as I mentioned, really, we've had more practices move to the contractual reform than the previous historic units of dental activity in the last year. So there are some practices who feel this is working well and are appreciating this move and clearly are voting with their feet as they're changing their contract models to provide NHS to the contract reform element. In terms of those, the challenge that we do have with dentistry, and I think I explained this previously, is that the contractual value is agreed up front. So we ask dentists what they can provide for the next year in terms of dental activity for the NHS. That is provided, and then we have regular contact sessions. So Rachel and colleagues in the contracting team support practices then to understand if they are going to be able to achieve that within the year, and we'll make allowances and discussions as the times go through. But fundamentally, if they do not deliver what they have agreed in terms of NHS provision, that contract value will be returned to the health board to try and provide support and additional services elsewhere, because we would rightly be scrutinised if we didn't claim back that activity value that wasn't being provided by those practitioners.
Okay, thank you.
Thank you, Lloyd. Thank you. Really comprehensive. Jill, are you satisfied? Yeah. Thank you. So, Del, I did note you had your hand up, but it's dropped off. No, you haven't. So we've got Councillor Howells next, please.
Thank you, Chair. Thanks, Lloyd and Rachel. Thanks for coming along today. I think my questions have been answered, to be quite honest, but I'll ask them nonetheless. So what steps is the Health Board taking to improve access in NHS dental care, particularly for those who are struggling to find an available dentist in the region? And can you did talk about waiting times and the portal there, but are there any current waiting times available? Any information available on the current waiting times? And finally, are there specific initiatives or programs in place? And I take your point on the community aspect there, so that they've probably already addressed initiative or programs in place to promote preventative dental care and oral health education within the community, especially for the vulnerable groups, such as children. I wonder if you have access to my computer, actually, so children and the elderly. Are there any initiatives setting up some sort of drop-in clinic for acute care as a safety net for those who have no access elsewhere? And also, I was going to ask, are there any, and I previously asked this, are there any initiatives to train new dentists and retain them in the NHS? Thanks, Paul.
Absolutely, no idea.
Okay, thank you for those questions. I may have to come back to you if I've missed any of those, because there was a couple of questions in there, but I'll try and make sure that I've covered them all off. First of all, in terms of the steps the Health Board is undertaking to try and ensure that there is greater access and availability of access for NHS dental services. Key thing really is whenever we do have a contract resignation, is that our aim is to re-provide that service within the areas of greatest need and or the location that they are required. So as a Health Board, it is difficult for us to do that because we are reliant on independent contractor models coming forward and being willing to take on contracts within the area. We have been, as I've already mentioned, been really successful in terms of re-providing all of the contract resignations, actually across all of Aneurin and Bevan, not just the 4 this year within Monmouthshire, and we have had new providers coming on board. So we are working closely, and Rachel and my colleagues meet with practices on a regular basis, understand the challenges, understand the needs, and trying to address those at a local level. And what we have done within Aneurin and Bevan University Health Board is, and I mentioned this very briefly in my sort of opening gambit, was that we have set up a sustainability board, and that sustainability board is chaired by the Chief Operating Officer within Aneurin and Bevan University Health Board. It is for all primary care contractors, so GPs, pharmacists, dentists and optometrists, but it has a series of a range of actions, and I'm sure we could share this in terms of the action plan with the committee, so you can see the key elements that we're trying to drive through. One is recruitment and retention, which we've talked about, ensuring that we're creating the environment that people want to work and live here. So we've had a very successful recruitment campaign, particularly around GPs, because of a comms campaign that we worked with Monmouthshire Council on. You may have seen the adverts where we've utilised some of the work, train, live programme effectively. So work within this area, train within this area, and live within this area in the longer term. So we have been successful in sort of creating those steps. We also have been trying to ensure that practices work closely together. So we have in the process and have already set up in a number of areas what's known as dental collaboratives. So this is where dental leaders within each area work with other practices in the area to try and ensure that the challenges are identified, brought forward to the Health Board where we can address them, and also then supported in terms of additional funding and opportunities through our neighbourhood care networks clusters to provide services within that area. We, as a NHS, more broadly, are part of the tripartite negotiations with Welsh Government and dental leaders, so we always ensure that we are fighting in terms of ensuring we have the level of funding we can to provide the areas of services we can for our dental services. Access is always the key question that we're asked about, and to your question in terms of what numbers are currently on waiting list, we do not have that data, and that's partly because we've talked about previously each individual practice holds that information, and there are advantages to that. So the advantages to it is if, for example, my practice is within us, and I live within us, and I'm on their waiting list. If they have a cancellation, they can go straight to the top of the waiting list and say, Mrs. Jones, you've got an appointment this afternoon, can you come and make it, yes or no? The challenge with that is we don't know the true level of demand behind it. So this dental access portal will be able to give us that insight into that level of demand and help us support people accessing the right service within the Health Board, because not only does it just add someone to a list, but it does have a series of triage type questions to understand what the need is. And in that, if it was an urgent dental need, it would direct them to our dental helpline and our dental urgent services that are available. And as I say, we're trying to maximise the use of those, because currently some of those urgent dental appointments are going unfilled. In terms of the communication, because it may be news to people here, the communication of the dental access portal, and that's because predominantly that is only recently being piloted in Powys and is this rollout programme across all of Wales. We're very lucky that we're going to be starting relatively quickly on the 20th of November, and we will be contacting and ensuring that our comms team shares that information as soon as we do have the designated timeframe for that. Rachel may talk a little bit about the access portal after I've finished. In terms of, your question was around initiatives for children, vulnerable groups, adults. So the two key ones are the Design to Smile, which is that children programme, and I sort of talked through that in relatively significant detail with Jill previously. The second is Gwan Am Byth. So this is the other end of the spectrum, so to speak. So frail, elderly, those who are in care home environments, or those who may be accessing day clinics within some of our community hospitals within the area, such as Chepstow or Monovale, accessing dementia clinics, etc. And it's to ensure that they are then provided with the right tools, support and education, but not just them, but also their carers. And that might be informal carers, or it may be formalised carers such as care home staff that are providing that support. We do have a population oral health programme which is within our community dental services as well, which sits outside of those two areas, but they try and tackle those high risk groups that you sort of talked around. So those who are maybe homelessness and not be able to access services in the traditional way, those who don't have access to IT infrastructure or ability to access services in other ways, as well as things like looked after children and those who need additional support as well. So we drive that through our community dental services, and those are provided locally as possible to whichever setting we can have access to, but also out of the community hospital sites as well. So within Monmouthshire, again, the Monovale site, as well as Bridges just across the way, and also the Chepstow Community Hospital site as well, in terms of provision of those services. The last point, and correct me if I've missed any if I finish, was just around acute access or urgent dental access. So during the pandemic, the requirement or the need for urgent access doubled. So, and that was predominantly because of the infection prevention control issues, which meant the throughput through community dentistry and general dental services had to be reduced to ensure that staff and patients were kept safe. As a result, we've put in additional on top of what we would normally have as routine urgent dental appointments within this health board. Our main aim is to make sure they're maximised, as was already mentioned. At present, across the whole health board, it's around about 20% appointments that are not filled on a monthly basis. Within Monmouthshire at present, and last month's data showed there was about 44% that were unfilled. And what we need to, and we're continuing to striving to do, is it because there's not the demand there for the urgent appointment? And if not, we can utilise that funding in a different way. Or if it is, and people aren't able to be aware of it or know how to access it, how do we support and manage that? So we've had lots of communications and comms with our GP practices, with our community pharmacists and our optometrists to ensure that if anyone is presenting with dental pain, they know how to access these urgent appointments. Similarly, NHS 111 has got a contact and link to our dental helpline, so if anyone contacts the 111 service and have got acute dental pain, they'll be able to be redirected to our dental services that way as well. We have updated our website to ensure that that number is right at the top of the website, so it's easily traceable. Searchable for those who want to search it, and we've had a number of winter planning events. So our comms and engagement team that's centrally within our Bevan University Health Board are going out throughout the community. So they've been to farmers markets, they went to the Usk show, for example, and in those they are flagging that information to those, because we are fully aware that not everyone is digitally literate or able to access the digital systems. So we need to make sure that people have that communication in a different way. So I think I may have covered all the points, but correct me if I haven't. Yeah. Yeah.
Chair, we can't hear.
Apologies. I was just saying, identifying the cattle market in Raglan as an area that might be of interest to them. And just my final point was any initiatives to train new dentists and retain them as well.
Yeah, so first of all, apologies. I had that written down and I missed that one on my list. We work with Health Education and Improvement Wales. So Health Education and Improvement Wales is a Wales-wide body who support the education and training of health professionals across Wales. They have recently, I think the last time I spoke, not in your open forum, which was probably this time last year, I mentioned they were going out for consultation in terms of a workforce plan. That has now been published, and that workforce plan leads up until 2029, so it's the next sort of 5 years plan as well as immediate. There's I'll share it with the group so people can access it, but there's a series of actions within that are for the profession themselves to tackle, for the health boards, for Health Education Improvement Wales, but also NHS, Welsh Government to address as well. There are bursaries that are available for people to access both dental training, but also dental therapy and dental hygiene training as well. So those are available and they are shared with sort of school leave as ages so people can understand what training opportunities that they have and how they might be able to support it into that role in the longer term. We are challenged more broadly across all of the health professions, as you would probably pick up in terms of social services as well, in terms of the ability to recruit and retain those individuals. And I think as we're moving forward, we are setting up as many initiatives as we can to try and keep and ensure those individuals are here. I think it might have been yourself, Marianne, last time we talked about potential sort of a golden handcuff element in terms of incentives to keep people in. The problem we have is if we're supporting that, we're taking money out of NHS provision elsewhere, or we're putting, so if I were, for example, to increase the contract value of an element being a golden handcuff, so to speak, then the challenge is I'm losing X amount of NHS dental care because that is what would fund the NHS dental care. At present, because we've been able to re-provide those services, we've not felt the need to go into that position because we've been able to re-provide all those dental services with, so maximising the public resources that we have available to us to provide that access. But it is an option that we do constantly review in terms of ensuring that if we had to, how would we potentially proceed within that area?
Thank you, thank you. Okay, so we've got, looking at the agenda, the list, but we've got Francis up next. Then we've got Steve. Ian, I see you're after that, but effectively Louise technically is a member of this committee, so you're going to have to wait, unfortunately, so thank you. Where are we? Yeah, so Francis.
Thank you, Chair. First of all, can I ask all of those figures that you've given us, can we please receive kind of a summary setting those out, please, Chair? Could we request that from Lloyd? Because he's taken us through quite a lot of information, a lot of figures, and I know that we've been furiously writing, but it won't make sense unless we have that.
So what Lloyd does, he kind of I've noticed his tactics effectively is, it's well intended, obviously it's not Machiavellian at all, it wouldn't be right, would it, to be? So effectively he just blitzes you with a lot of information, and if you're smart you'll pick up on little bits along the way, and then you'll come in and look at the way, I mean, very impressively answered Marion's questions there, but you're bedazzled by some of it. So sometimes it's good to kind of stop, take a breath, and then come back to the question. So Francis, far away.
But yes, it'd be very helpful to receive that so that we can share it with our colleagues as well, because I'm sure they'll all be interested too. So I've got 4 questions, but the first one is, so you've been saying that all of these contracts in Monmouthshire have been re-provided, which obviously sounds very positive. Can you please explain to me in layman's terms then, how many people were receiving the services of these, the kind of old, retired, whatever you want to call them, when they relinquish their contracts, and now have we got a commensurate number of people accessing service through the new contracts? I appreciate that what you're trying to say, I think, is that you kind of look at units. So if someone goes once in a year, that's how can we understand if the people who were receiving dentistry, NHS dentistry services before are receiving them now? How can we understand any differential in take-up? And if there are people, because my understanding, because I've heard them when I've been in the dentist surgery saying, are you taking on NHS patients? Some of them will be saying, oh no, and I will be taking them on in October or whatever. Where are we with that? I appreciate what you said about the common portal and you don't have all the data, but how best can we understand the position that we're in now? That's my first question. I'll ask them all because then you can just get on to answering them with lots of facts and figures, I'm sure. Some members have talked, and you've talked about the change in the provision of services, where people now no longer get their 6 monthly checkup, etc., but they go as they need it. But for children and young people, my understanding is that they have a yearly checkup now, whereas they used to have a 6 monthly check. Now, notwithstanding, Design to Smile is a fantastic service, but it only accounts for a tiny, tiny proportion of children and young people. What impact is the change where we're reducing children and young people being seen having on, for example, onward services like orthodontic services? Do you know? I mean, maybe I don't know if you know yet, or what do you think it's going to be? So that's the second question. What is it doing to the referral rates for onward orthodontic treatment? And then finally, what is the actual current waiting time for orthodontic treatment for children and young people? So those are my 4 questions. Thank you.
Thank you, Francis.
Thank you, Francis. I'll come in on the first one in terms of the re-provision. So if we take the most recent contract termination from Beaufort, we work with the practices and with our Business Services Authority, who are able to provide us with a list of patient numbers, so that we're able to sort of retender on the basis of X amount of patients. So there was 8,400 patients affected by the change with Beaufort, and our tender process goes out on the basis of we are looking to re-provide for those 8,400 patients. And we split those ideally based on where these individuals live, but like Lloyd has described, it does depend on where the contractors come forward from as well. So then we try and split those on the contract value and the additional number of patients that provider is able to take, and then B then on the closest provider to where these individuals live. So essentially we are looking at the whole patient list that is affected by the change. We write out to those patients to let them know once we've gone through the process and we're able to confirm that we're able to re-provide, we let them know which practice then they have been assigned to. Obviously, because there isn't registration within dental practices, they may decide that they wish to stay with the dental practice if they're offering an alternative to NHS provision, or they may decide that they want to seek alternative provision themselves, and that's what some of the patients have done. But ultimately, we do write to every single patient, so we do look to provide for every patient that's affected. If then patients decide that they want to go elsewhere, we don't reduce what's been allocated to the new providers, so that essentially then enables them to be able to take on additional patients if they've got a list of themselves or they're taking phone calls.
Okay, thanks, Rachel. So just in terms of the other elements then, so you talked around the impact of the new contract for children. So I guess the key bit around it is a needs-based risk assessment that is what's undertaken now, which historically wouldn't have been the case. So as part of that sort of acorn element that we talked about earlier, what it does require is that for Flora Advantage, if it's not undertaken by the Design to Smile team, that the practice themselves cover at least 80% of children aged 3 and over. So the big risk is dental caries. So that's the big risk that we're trying to manage the support for children. So there is an assessment that is made then. So it's a traffic light system, red, green and amber, and then that would base in terms of the appointment. So many patients or children who would sit within that red area would be seen more frequently than once a year. So they might be seen 3, 4, 5 times a year, whereas those who are in the green area would have that longer term period that is provided. In terms of impact, it is relatively early, unfortunately, to try and work out the impact because, as I said, it was 2022 that the new contract come into play, and we didn't have wholesale, so every practice wasn't providing contract reforms. So at present, we're trying to understand if there is or isn't an increase in terms of orthodontic issues, for example, as well as other issues, because, orthodontics is one part of the oral health system that we're trying to support and manage. What we do know is actually the pandemic has resulted in increased referral rates into orthodontics. So in 2019, we had approximately 2,200 referrals into the service. Since the pandemic, so that's doubled. So in 2022, we've had 4,600 referrals in. Last year it was 4,900, and this year, thus far, so up until September, we've had 3,500. So those numbers are increasing significantly. It's a challenge because, as I said, those numbers went up before the new contract come in, so we can't correlate that those two are related. But we also manage it in terms of the child health element and some of the contributing factors that might cause issues for orthopedics. We only have one orthodontic provider within Monmouthshire, and if we were able to fund and have additional orthodontic providers, we would be doing so. And I think one of your questions was in relation to the waiting time for children within orthodontics. We don't have that split, so we have a total waiting time for adults and children, but children would have priority over adults within that system. And at present, it's between 3 to 4 years that there is a waiting time for orthodontics. And we, whenever we do have additional funding or opportunities to do so, we will put that money into where provider is able to do so, additional orthodontic assessments, procedures, etc. So we're able to try and tackle that waiting list as we would any other health board. on your very first question, Francis, so what I did last year when I came to this open committee, I shared a briefing paper after the session, so more than happy to share that with the members. Well, I'll share it with Hazel and the chair, so they'll be able to share it with members as required. And as I've said, and the chair mentioned at the beginning, we don't have to come to this committee meeting, but we want to work closely with the members here, and we'll be open to keep this sort of dialogue going. So if there's anything in that paper that comes across, or anything I've said today or my colleague Rachel has said today, we'd be more than happy to pick up again in a further meeting if it was something that was appropriate. And apologies if I didn't cover all 4 questions. It was just check before.
No, thank you. I'm just going to say, very, very brave of you to. We haven't even got probably halfway through the meeting, and you're already offering to come back again. I mean, I'm going to let the dogs loose in a minute. So Peter's here. Look,
Chair, may I just come back on just a point of clarification there. Sorry. So thank you for your responses. Just on the first point then, with regard to the reprovision for the
Francis.
Yeah.
So no, I absolutely was going to let you come back. I was going to try and be helpful in as much as that I was extremely concerned about some of the explanation about the waiting list there. But again, what I was going to say is that Lloyd's got his notes, his crib sheet. We need that really, Lloyd, to give us some kind of a chance of at least a fair fight here, really, to understand precisely what's going on for next time. So if that's possible, as you've already invited yourself back again for the next quarter, that would be great. Is that all right? Yeah, Francis, go ahead.
So thank you for your responses. I think what I took from the response to question 1 is that we don't really know at the present time. Would that be fair? Because you've written out to people, but we still don't know. So that said, do you think that this dental access portal is going to help us understand that? I wanted to come back on that. And then just to say, I mean, clearly we could comment a lot about the potential waiting times and stuff. And yes, orthodontistry is only one point, but it does give us a good indication of what general population issues are. I mean, that's an incredibly long time, a really long time. I understood that it was, maybe 2 years before that significantly higher. But then, and then on question 1, the point I wanted to ask was, so if I was attending Thrive in Mega here, where would I be re-provided to? Where have I been offered to? My understanding is that's quite a travel. Can you just confirm that for me? Thank you.
Okay, so yeah, I'll come back in there. I think just to come back in on a point, I'm more than happy to have shared anything prior to this meeting as well. Just obviously we weren't asked to do so, and you talk about a fight. I'm not here to fight. I'm here to work collaboratively with yourself.
In effect, no one's no one's going to get you a headlock, and that's not going to happen. Yeah. It's purely political speak. So debate. Let's change the word from fight to debate.
Yeah, and I'm happy with that. And just and to be clear, I'm not here with any political affiliation. I'm here as a health board trying to provide care for the patients. So, just in terms of your 2 questions on the back of that. So, in terms of the reprovision, we reprovide the level of dental activity that we had in previous. So that will be the same. Yes, in terms of knowing the numbers of people we allocate, that is how, so that should cover off the same number of people that would have the same number. So there shouldn't be a reduction in any NHS dental services. We've been successful in being able to re-provide that full element. In terms of Thrive Dental, so that was based in Mega, within that area. Now, the re-provision is within 7 Dental, which is in Caldecott, and I appreciate that is, not in Mega, so it is an additional travel that is available. What we do as a health board, so again, we don't, as a health board, commission public transport. That's not the role of the health board, but what we do because of issues like this is provide community transport schemes or fund community transport schemes. What I'll do is I'll ensure that details of the community transport schemes are included in the summary report that we provide to you, Francis, so you can be aware of that. The dental access portal, from our understanding, we regularly speak to all our contractors to try and gauge the level of waiting list that they are holding. They're only as valid as the day you ask the question is part of the issue. So we are going to hopefully have great benefit from the dental access portal because we'll have a live, up-to-date understanding of where we are in terms of access and need. But more importantly, we can use this then to go back to Welsh Government and say, our demand within an Iron Bevan is X. We are funded to provide Y. How are you going to support us in terms of being able to provide the access and services to the demand that we are seeing within an Iron Bevan Health Board?
Thank you, Francis.
Chair, can I just chip in?
No, you can't.
Okay.
So sorry.
Seven Dentals in.
Sorry, no, but you can. You can chip in at the end, though. Absolutely. Yeah. So, Francis, have you got any other questions?
I was going to say I thought it was Chepstow. Sorry, Jill. But also, can I just say thank you for your responses? And I think it would be perhaps if we do want to have some information from you in advance, we can try and provide a couple of points that we'd be grateful for. But yes, that would be really helpful. Thank you very much.
Okay, Steve.
Thank you, Lloyd. I've got 3 questions. I just wondered how regularly are patients able to get hygiene appointments with a professional hygienist? I have to go to a private dentist because that's the only dentist I can get. I have to pay, but I just choose to pay. But I wondered whether on the NHS there is availability for. I see my hygienist 4 times a year, and that's very important to my dental health, I think. And I just wonder whether that's available in Monmouthshire. With the 40% of appointments for emergency treatment that aren't taken up, does this have an impact on capacity for dentists to see other patients, or is it just built into the day that they would basically see anyone that was going to come in with an emergency anyway, that there's no impact on the number of appointments available? But if there were an impact on appointments, is there any way you could look at how those appointments could be reallocated so that maybe more regular appointments can be given, or those people that are struggling to get registered are able to get seen at least provisionally by a dentist? And then my third point is around the brushing at school. I think it's a great initiative, and I know that the professional bodies, some teaching professional bodies, weren't so keen on the idea a couple of years ago. How has it gone down in schools in Monmouthshire? How are teachers and pupils reacting to that? Because I think it's a great initiative. I'm disappointed that some parents don't think it's something their children should participate in, but it's a really good initiative to promote oral hygiene, and children doing that together, I think it builds up that kind of confidence and that awareness of how important it is as they develop. And thank you for your responses so far as well. Thanks.
So first of all, thanks, Stephen. And just on the previous point, I did misspoke. Sorry, 7 is in Chepstow, and I may have said Caldecott, I think, instead of Chepstow. So apologies for that omission. On the last point, first, Stephen, if that's okay. So it's been very well received in terms of the school settings that we've been providing the services. So we have only had 2 refusals from schools within that area out of the 12, so 10 have undertaken that. As a comparison, I guess we have had much higher levels of refusals in other local authority areas. So we have also found that it helps build sort of a relationship with our dental practitioners as well as the school staff as well as the children. So some people do have fear of attending a dental practitioner site, and this is hopefully tackling that at a very young age. So we're not sort of coming into the stages of later life and people not accessing dental care through fear or concern of doing so. The first question I think you asked was with regards to the urgent access free appointments that are not filled. So this is probably where the benefit of that localised waiting list comes into play, because the practice, if they know that this afternoon they haven't filled any of their urgent dental appointments, they would then say, well, okay, I've got X on my waiting list, I'll call Mr. Jones in to come in to fill that appointment. So it gives that flexibility. And what we're going to be really mindful of is how the dental access portal may or may not support some of that flexibility in terms of where we're with it. So, and for us more broadly, it's always trying to make sure that we've got the right balance of urgent care versus access to routine care, because we want to make sure, you know, as I've sort of talked about right at the beginning, that we are on that preventative agenda, because a significant amount of dental issues can be prevented if tackled early enough, routinely managed and supported in the right way. In terms of the hygienist question that you acted, so I'd have to go away and check the detail on it, but it would be based on a needs-based assessment, which is what the new ACORN element is. So you may well require or need 4 times a year hygienists, and there may be patients elsewhere who would do so, but the practice themselves would have that undertake the needs-based assessment through the clinical examination, and then, depending on what the needs-based is, would be able to address that. So it might be 4 times a year, it might be 6 times a year. It depends on that needs-based assessment. And as I said, that's the real value in the new contract. And just be clear, we implement nationally agreed contracts, but what we see as the value of the new contract is that the right people are being seen at the right time and having the right support for them, as opposed to routine elements that may or may not be beneficial for those patients.
Thanks, Lloyd. So we've got next. Are you happy with that, Steve? Have you got any supplementary, Steve?
No, that's great. Thank you very much. Thanks, Lloyd. Thank you.
Okay, so Louise, you're next.
Yes, thank you, Chair. I was wanting to find a bit more understanding of how it worked in practice. I think initially you said that, if I got the figures right, that 10 out of 76 practices were NHS in 9 centres or something like that. If that's only about 13% of all the practices, so I wondered how that compared to other health boards in terms of their percentage. And on the primary school side, I think you said 10 or 12. Well, I think there are about 30 primary schools, so that's possibly more nearer to a third, and I just wondered how that compared to other areas as well. In terms of the practicalities, I mean, obviously a number of practices in Monmouthshire have closed, and they've been there's been procurement activities, but obviously, geographically, patients aren't necessarily where they want to be. For example, in Mega might be nearer to Newport and than, say, people in Chepstow going to Newport. And I just wondered whether you would allow patients to transfer from one list to another internally within the practices, so that they were closer to their NHS dentist. The other question I've got is basically, I'm a little bit concerned about this risk model, because basically it was sort of a 6-monthly check, and then it went to a year check. And my concern is the regular checks would be calling in patients who wouldn't necessarily have their teeth checked, and it's more of a preventative measure. And I'm just wondering about this risk assessment, whether it actually people fall through the net as a result of a change in this. And then the other question I've got is, how does where the patients have been allocated from a closed practice to a new practice, how does that work in terms of, do all the new patients for that practice then get a checkup, or is it just a question of them ringing up when they need care? Because I did, just out of interest, I rang Seven Dental, and I was told at the moment they're just dealing with urgent cases, at least until Christmas. So I just wondered what the schedule was when people were taken over to a new practice. Were they called in for an appointment, and how did that operate? And then in terms of your emergency care system, when I was at an NHS practice, I did have, you know, I was in danger of losing a tooth, and I did go to ring up a weekend and go to, it was just late on a Friday, and then I did bring up and go on a Saturday to an urgent care thing at Newport, but it was a temporary filling, and then I had to wait for 6 weeks to get it actually refilled. So I just wondered how in terms of your urgent treatment, how far does that treatment go? Because the problem is that if you have a temporary filling but you don't have a dentist, you know, you actually need more care. So I'm not quite sure how the system operates. The other thing is in relation to this dental portal. Presumably, this will be on the Health Board website, and I just wondered where people would actually find this information, and you know, if you were going to sort of print leaflets for libraries and so forth. There's quite a few questions there, but I don't really understand how your new system works in practice, and that's my main question area, really.
Thank you, Louise. Lloyd.
Thanks, Louise, and I'll try to jot them down as we've gone in terms of the types of question. So I just want to provide clarity at the beginning. So Aneurin Bevan has got 76 general practice contracts. The 10 is Monmouthshire, so the remaining elements are broken down across the other boroughs. So
yeah, I wasn't. Kate, your statistics came so quick. I wasn't quite sure.
No, and that's fine. And as I said, I'm more than happy to share that with you.
So is that how many? I mean, in terms of relative terms, then how many practices are there in Monmouthshire, and how does that 10 compare?
No, so there are 10 NHS contracts within Monmouthshire, 76 across the whole of the Health Board. It's based on a population basis, so there's 600,000 patients within Aneurin Bevan. So we've got a split then that there are 11 within Blaenau Gwent, 25 within Caerphilly, which is our greatest population area, 14 within Newport, and 14 within Torvine. So Monmouthshire has got, as per population basis, the level of dental activity that is appropriate for that area. You talked a bit about the school eligibility settings. So the Design to Smile programme focuses on areas of deprivation. So what the programme will do is target those primary school settings that are in the areas of greatest deprivation. So there are 12 within Monmouthshire, which is the 12 I was referring to, and that 10 then obviously has actually taken part in that programme, with 2 that have refused. So the programme can't cover every single school. It needs to be focused on those areas of greatest deprivation and need, where it's going to have the greatest value. Broad, and I'll just be clear, it's not this Health Board's contract. So this Health Board implements a Welsh Government agreed contract with the dental profession and the wider NHS. In terms of what we see and the benefits that have been provided, is the assessment is comprehensive. It covers off clinical oral risk as well as needs. So it isn't. We at present have not seen those who are missing or going through the gaps. It's adding value, which a routine checkup for every single person who was on the NHS list at 6 months was not adding that value that this clinical assessment and routine-based sort of risk-based assessment is provided. I'm going to stop a second and just hand over to Rachel, if she's okay, to cover off the dental access portal question that you had.
Thanks, Lloyd. Yes, so the Dental Access Portal, as Lloyd said earlier on, it is moving quite quickly. So there will be communications on our website and through various other arenas through our communications engagement team. We are sort of taking a slow approach to that until we're in a position where we're able to be up and running. As Lloyd said earlier, our go live date is in November, so we need to make sure we've got everything lined up and ready to go for that. But what we will do in the Health Board is recognising that not everybody will have access to the digital sort of platform. We will have a dedicated phone line where we're able to take calls directly and support people to access the portal and to get their name sort of registered on there as well.
So I don't know if I've missed any of your questions there, Louise.
Yeah, sorry, I had quite a lot. Yeah, I don't understand. You know, for example, in regard to the list that was the number of dentists that were closed in to stop taking NHS patients. What's going to be the procedure in terms of calling those patients on that list, and how long are they going to wait, or is that up to individual dentists on how they operate, or you know, how does the system actually work? And I think the other question I got is, if there's 10 NHS dentists in Monmouthshire, how many dentists are there as a whole in Monmouthshire, you know, so that we get an idea of the percentage that the NHS is actually covering?
So in terms of when patients are assigned to their new dental practice, we do ask that sort of priority is given to children and to those that are already in active treatment. So they may have started a course of treatment with the dental practice before it's closed. So we need to make sure that those are prioritised. So the routine care and the routine access might come on a little bit slower or a little bit later once everybody that's in active treatment, so that there's no sort of urgent need arising from that. In terms of the sort of private and NHS mix, we don't have any sort of governance around the private dental practices, so we don't capture routinely what level of private provision is out there.
No, I just wondered how many dentists there were actually in Monmouthshire, and how many of them are NHS dentists.
So we, as I said, we know that there are 10 NHS dental practices, and we can get the workforce data in terms of the physical number of dentists who work in NHS practices, but we wouldn't hold any information in terms of the private providers who are purely providing private services. It's not something as the Health Board we commission or collect in terms of data. So,
sorry to interrupt me. So, Louise, am I right in thinking that you're asking those that are contracted specifically just to be NHS? Have we got any of those at all?
So the question is, how many are just purely provided NHS? Yes. Yeah. So the 10 NHS funded contracts, and they may provide elements of private work as well, yeah. But we only have contracts with 10 dental providers for NHS in Monmouthshire, just to be clear.
Louise, is that helpful? I'm not sure it is, really. Is it really?
Yeah, I think I was thinking, you know, if there's sort of, I mean, obviously there's dental practices in each area. I mean, some of them specifically just cover private. Some might cover NHS, and some might cover a mixture. So in terms of the provision that's provided in each area, if you have figures on those numbers, which I presume could be fairly easily provided, then you'll have an idea of what sort of percentage you've got of private patients as opposed to NHS patients, and it gives you a better idea of the NHS cover that you've got. I think the other question I asked was about the urgent treatment and what people did who went for this urgent treatment, and then it was only of a limited amount and they hadn't got a dentist to complete the treatment. How did they fare?
So just on that private point, because they are private providers, they have no obligation to share any information with us as a health board. So we don't have and can't take that information from private providers. They are the data controllers. They hold their data in terms of who they see and the numbers that they see. So we don't have access to any private numbers of patients that are seen. We will probably be aware that there'll be patients who are accessing private care but also sitting on an NHS waiting list, and will access private care for certain elements of care and come back on the NHS waiting list. As a health board, the only information that we have available to us is what is NHS provision and what we commission and fund. It's the same as any other private company. They would not share data in terms of their activities for things that are not commissioned by the health board for them to provide. In terms of your second question around urgent access, so the urgent access appointment would be for what is required at that point in time. So it might be that a temporary fill-in is required, or it might be a full element of treatment is required. It would be on a patient-by-patient basis, and it would be availability of the appointment slot as well that you have got with the dental practitioner. That would be purely based on the dental practitioner and what is available and can be provided for the individual needs at that time.
So if for example, say for example, a Newport practice does a urgent dental surgery. Does that mean that if somebody comes along and doesn't have a dentist, then they will complete the treatment?
Yes, that would be the case.
Okay, thank you.
Thank you, Louise. Thank you for those questions. Louise is a substitute today. She's come on. She's like super sub. She's rocked up with some really good questions there, so thank you. I have got Dale next. I'm sorry, Ian. So you just have to be patient, and then you can come in. Dale, please.
Thank you, Chair. Replacing like-for-like contracts is all well and good, but what are you doing to address the population growth that we're seeing within the county?
Thanks, Dale.
So thanks for the question, Dale. So we are limited in terms of our funding that is available to us as the NHS. So we will maximise as much as possible that our ring-fence pots that are for dental services. The population growth is across all of Aneurin and Bevan, as you will know. So we will, where possible, and additional funding allows, increase activity and provision to ensure that we are capturing increased population areas as needed, but we are unfortunately, Dale, held to the availability of funds which we are allocated via Welsh Government.
Dale, have you got any supplementaries?
No, Chair.
All right, thank you, Lloyd. Ian, if you wouldn't mind.
Yeah, thanks, Chair. Yeah, and thanks, Lloyd and Rachel. It's really interesting to be able to dive deep into this. And it's really helpful for us. But inevitably, of course, we're going to have concerns and questions. A simple one maybe to begin with. To what extent, how does the Welsh NHS dental contracts differ from the English ones? I noticed that Joe Stevens, Secretary of State, said that Wales was an example to England for dentistry services, and I know that got a lot of pushback from the BDA and others. So that was a simple one. I think my probably more challenging one, and I think it builds on some of the other questions, is about what's your overall assessment of need as a health board in terms of what is the need and the unfilled need, in particular for dental services. So we've talked a lot about NHS contracts and obviously the majority of adults will use private dentistry rather than on NHS, I assume. I'm a little bit worried that you don't, even though I fully accept that private dentists don't have to give you patient data, but to not have a mapping of what is the provision of services around for public health in Gwent or in Monmouthshire in particular, and what's being fulfilled privately as opposed to through the NHS, I think is concerning. But that eligibility, obviously all children are eligible for NHS services, but in terms of adults, only some are according to income level. But where do you feel, what's your assessment of people that, not just on waiting lists, because that's actually only a very partial measure of need, is what are the number of people that are not actually having the dental services that they should be having, so essentially getting dental problems that are untreated for whatever reason, either because they're not going private or they can't access NHS. So I think that's that sense of, because a lot of data, and I'm not just about dentistry, but a lot of health board data is about services provided, less so about need that's not met. And I think that's what I'm more concerned about, is where is the need that's not met. And then I suppose the final one, which again may be one for Rachel, I don't really fully understand the implications of the fact that what you're saying, that patients aren't registered with a dental practice in the same way with a GP practice, but at the same time, obviously, when the contract finishes or is terminated, you're contacting a number of patients who are on a list. So effectively, they are registered. But is that just a different format? Because otherwise, I'll be worried about where's the continuity of care, where's the shared health record that follows the patient from dentist to dentist. Those types of practicalities, I don't really understand that aspect of it. Yeah, and well, I'm really worried about the 3 to 4 years waiting time for orthodontics, because a child's mouth can change so much in 3 to 4 years that timing, I know, is critical when it comes to orthodontics in children. But anyway, you don't have an answer to that, I'm sure, but just registering my concern on that one.
No, so again, thank you for the question. So just to be clear, that 3 to 4 year waiting list is for the total orthodontic population that referrals that have come through. So we haven't got the split available to be able to share with you in terms of what that is, but children will be prioritised, so it will be significantly lower than that. In terms of the changes on a yearly basis of a child, so they still have their reviews that would be planned throughout that period. So if there is significant changes, the risk assessment score that is done will be reflected, and that might change their position on that waiting list. So that is sort of a monitored process that works through. In terms of need, this is the real challenge that the Health Board has when there's a provider that is private but also can provide, we provide NHS services. So what we do as a Health Board is try and make sure that we've got the provision to provide dental services to the population of an Aneurin Bevan. So our basis is the population of this Health Board. So that's what we're commissioning services for within the resources that we do have available, and that's what we aim to provide. We are slightly held, as I've already mentioned, because we don't have access to the full data, and we never will be able to access that data because those providers have no obligation to share it with us. Some people will access services outside of this Health Board privately, outside of this country privately as well. So we're never going to have a true indication of the total dental need, but also some of the dental services that are provided privately are not services that would be routine NHS elements of care. So they may be for aesthetic reasoning as opposed to purely management of care. What we do undertake is population needs assessment, and we work with all the local authority areas under the Regional Partnership Board to understand what the whole population need is. And this is why also then we focus particularly on children's health, because we know getting things right from the start of life is key to improving then oral health hygiene throughout that time period. And we also try and ensure that we're looking at where we have the data for waiting lists on independent practices, using that information to inform our decision of where we try and re-provide services where we can do so. As I said, from our perspective as a Health Board, ideally we would want access and availability to all of the data that's available, but we wouldn't want to necessarily, even if someone is having services privately, not make a provision for that population to be able to access NHS dentistry services as we can provide. We, as I said already, go to Welsh Government on a regular basis to try and indicate what our level of need is and our level of demand is. And this is something that the Dental Access Portal, I think, will actually bring a benefit to us, because what we will have for the first site is a true system that we can look at and say, this is the level of demand that we have presenting within this area. And yes, it may not be 100% accurate in terms of, people might not access that portal or put their details onto that portal, but it'll give us a much better understanding of where we are than where we have been. And it will also, importantly, be an indicator for Welsh Government to understand that and how that looks across all of Wales. So just to be clear on the Dental Access Portal, it's a service that Welsh Government has put forward, and it's going to be held on Digital Health and Care Wales' website with a link from our website in Aneurin Bevan, so people don't have to go numerous places. But then that will also inform the conversations and the negotiations that Welsh Government have with the likes of the BDA and colleagues in terms of how the contract reform will continue to amend. I mentioned previously, I'm not here with any political affiliations, and some of the conversations that you talked about in terms of England versus Wales contract does unfortunately fall within that area. For us, from my personal view, in terms of the contract reform contract that is in place, it is that it's more of a needs-based approach. So what we're actually trying to do, you may or may not be aware of the inverse care law, which means that those who are in the greatest need of care are often the ones who are unable to access that need of care. So what we're trying to do through this contract is to ensure that it's a needs-based approach that will mean that those people in the greatest need have the ability to access that care in a more appropriate way, as opposed to what was previously a unit, as it was called, units of dental activity, so purely a unitary approach to the management of the population. There is certainly more that could be done. I wouldn't want to be sat here, saying that as I did right at the beginning, that NHS dentistry remains a challenge, because it does, and we're trying to, as a health board, support the profession and work within our resources to be able to provide that care to the population that we serve. So, is there anything you wanted to add, Rachel, in terms of the dental access portal, or no?
Could I just clarify then? So, in terms of the English NHS contract, it's about units of care. Is there a financial difference as well in terms of the payment per unit, or is that more equivalent? Because I suppose that's I suppose where the difference is. It's the nature of the contract, but it's also the level of the contract, I suppose.
No, in terms of the level of pay, England versus Wales, I'm not clear on what the difference is. In Wales, where we've got units of dental activity and contract reform, the actual total contract value is the same. It's just how they meet those metrics within those different contracts. It differs.
And just on that point, what we're not seeing is dental practices moving across the border. What we're seeing is dental practices moving away from NHS provision. And that's always been the case, because we've always had contracts come and go. As I said, this year we've had 6, which is more than in previous years. But we have been able to re-provide all of those contracts, which is an indication that there is a significant interest out there from dental providers, just maybe not the same dental providers that there has been, and more of an interest in terms of moving to the contract reform contract. As we've seen, as I've already mentioned, more of our practices move towards that this year than in previous years, across all of Aneurin and Bevan, but within Monmouthshire as well.
Is there any other questions there? I know Jill wants to come in. I noticed that, Jill, you had your hands up again.
No, I didn't. That was just about the Chepstow Caldecott 7 dentistry. That's all. Thank you.
Okay. We've got Emma here, and we've got Peter. Peter, you've waited patiently. I just wondered if you've taken a lot of interest in these subjects, both of you, historically. Have you got any questions you'd like to put forward?
Nothing particular. Again, as I say, I was here to listen and learn. It does seem to me there's been some improvement since I had a bit of a go when people from Roggett were directed to Monmouth, and that was described as local. At least now people seem to be being directed to Chepstow, which is a lot easier, and also to Newport, which all of that can be problematic depending on bus routes and where the surgeries are, and that sort of thing. So things seem to be improving, although, to go back to Lloyd's opening words this morning, it's still a very challenging situation. References have been made to comms, and I'm fully aware that comms is a huge nightmare nowadays. There's no one way in which you can easily contact everybody. But I would stress that local councillors, I think, have a role in that. We know the local sources and so on. For example, in Roggett, there's the Community Council produce a magazine that goes to every household twice a year. We could easily put something in there with the numbers and so on. So use your local councillors is one thing I would say. Thanks very much for giving me the opportunity there, Armand. Thank you.
Not at all. Emma.
Hi. Thank you, Armand, for giving me a chance to speak today. I have one question that I believe Ian asked, but I don't believe it was answered. It's to do with the fact that now patients are no longer registered with individual dentists. in which case I don't quite understand what the waiting lists are. If nobody's registered with anybody, why are there waiting lists? What are the waiting lists for? And how is there then a consistency of care when you're registered with one dentist, that dentist knows not only your medical needs, but also your I was a dental assistant for a little while, and they also know your personal history, and the knowledge of a personal history of a patient can put that patient at ease when a lot of patients are nervous. And if you already know that patient is nervous before they come in, there are certain things that you can put into play to make sure that they're at ease before you see them. My other question is, I have residents here that were patients at Beaufort Park, and since its closure have now been offered spaces at St Julian's, which is not only 18 miles away, but I would probably say is probably almost impossible to access by public transport. And yet I understand that Trevenoid Dental Surgery in Monmouth have capacity and a desire to expand their NHS capacity and are awaiting funding for that. Can you tell me if there are plans to expand provision here in Monmouth where public transport is a particular challenge for residents, and they're not offered places in the far reaches of Newport, which is not really suitable, I would say, personally. And also, can you say if the NHS are not keeping a register of all the dental practices, both private and NHS dentists within Wales, who is there anybody actually keeping a register of provision and standards of dental care overall in the county and in the country? Diolch yn fawr.
Thanks.
Thanks, Emma. I'll just come in on the first point, and apologies, Ian, that we didn't cover that off. And like you, Emma, I was a dental nurse for a little while, so I do understand completely what you mean around continuity of care. But it is different for dental practices. Patients are not registered in the same way that they are for GP practices. But what we do has if you are known to a practice, so if you've accessed routine dental care within a period of 4 years, then you sort of belong to a dental practice, and that's where we talk about keeping up with your regular appointments, however that is set for you and what is right for you. When we have a contract termination and we sort of take the list from the practice and from the BSA where we look to reassign and re-provide that provision, that is an additional step that the Health Board does to try and make sure that everybody that's affected by that change does have access without having to ring around and join waiting lists themselves. So that is why we ask for the patient details and the patient list, and that's why we write out to those patients that are affected to try and make sure that they don't sort of have any gaps or have to join the back of a waiting list at that time. So that is why we do that step.
Thank you all for coming along today. Francis. Francis, you've got a question, I believe. Supplement.
I asked 3 questions. Is it okay to have the other 2 answered?
Go. Yeah, absolutely. Go for it, Emma. Absolutely.
Sorry. Is that okay?
Yeah. So I think the second question then was particularly about a practice called Trevenoid in Monmouthshire. So Trevenoid did have 2 NHS contracts because it picked up an additional contract in 21-22. Now that practice then were one of the ones who returned their NHS contracts. So they did have 2 and now they're down to 1 NHS contract. So that would indicate that they don't have the capacity to continue and have additional NHS members come in because those were one of the ones that terminated on their second contract on the 31st of March this year, one of the ones that we needed then to re-provide services. So every time that a contract is terminated, we go out for procurement. It's open field to whichever practice wishes to be involved. So if you know something separate to us in terms of Trevenoid Dental, in terms of their ability to take on more practices, then if and when there is any additional contract resignations or funding available for additional NHS patients, then they have the ability, like other dental providers, to support and access that. And then
okay. I was told that they have a waiting list, and I know I have members that have been offered spaces in St Julian's, which is a really long way for people in Monmouth. So if you're saying if they have a certain, once their waiting list is a certain level, because they said they have got a waiting list of members waiting, because I think they're the only NHS dentist in Monmouth, aren't they?
So it's nothing to do necessarily with the waiting list, is that they returned a contract to us. So they had funding to be able to provide additional NHS services, which would have tackled that waiting list, but that was returned to us, as I said, on the 31st of March. I'm not going to speak on behalf of that practice as to why that was done if they do have a waiting list, but that is a sort of a separate issue that they may or may not wish to pick up. As Rachel mentioned, really, because those St Julian's cohort of patients, they can access NHS dental services anywhere. As we mentioned, it does mean that the closest local area that has the availability has been allocated as St Julian's, but we'll be able, they'll be able to put their name into any of the other practices, and the new dental access portal will mean that they just do that once, and they don't have to put their list on every practice within that area. I think you then asked a question just around dental practices more broadly, so private or non-NHS. So as I said, NHS, we would know all of our dental practices that we provide commission for, and there's a register for dental practitioners, which we monitor, ensuring that they have the appropriate skills, knowledge, etc., and professional behaviour to be able to provide NHS dental services. They are a registered profession, so their registered body would hold the full details of dentists who are able to provide private and NHS and private services, and any health facility would be covered under the Health Inspectorate Wales in terms of management as well. So not the NHS. NHS, as I say, we focus on NHS provided services, so we would know all our NHS providers of dentistry and the registered professionals within that trade, and then it would be other organisations, as I've just outlined, who would cover off more wider systems.
Thank you, Rachel. Thank you, Lud. This is the end of the meeting. I just finally get to ask my questions. I'm sorry if. Oh, Francis, thinking act. Francis, have you got a question?
I know it was just on that point really. So just to be clear, my understanding is if you change practice, you change dental practice, and obviously there are going to be a lot of people who are changing the way in which their dental care is provided because of the changing contracts. There is no record, there's no records at all. They will not transfer with you to your new provider at all. So when you say that we're not, people are not registered, my understanding is if I was with Thrive Dental Care and then I'm not, and I have to travel all the way to Chepstow to use a dental provision there, no matter how complex or to what extent I might have particular issues, those records won't be available to the new dentistry service. I think I'm correct in saying that, aren't I? And I guess from my point of view, I was just wondering, what kind, because this is obviously occasionally that happens, people change practices, they move, etc. But actually there's a lot of people, aren't there, changing practice services. So have you got any thoughts about what impact that might have on what people's oral health? That's the first thing, and just generally. But then secondly, we will get this kind of process map of where people have gone to, where the contracts have gone from and where they've gone to, and maybe have that mapped out on a Monmouthshire map, because as Councillor Bryn says and others have said, people are finding themselves potentially now travelling quite large distances. They were already having to travel for, like you said, there's only one orthodontic provider in Chepstow, which is obviously is a very long way to travel for anyone requiring those services, unless you're obviously local to Chepstow. So that's kind of it's quite a complex picture, really, isn't it? So yeah, I wondered if you've got any work going on to look at what impact all these changes are likely to have. I'm not expecting a long answer. Sorry, Chair, I just jumped in, but I thought that it was important for us to ask that and maybe ask something to come back the next time.
No.
Thank you, Chair.
No, I mean, if Lloyd wants to kind of cover this off now, or wants to, I think it's probably one for, ongoing work, which would, dovetail into me saying that we will obviously invite Lloyd back. I'm sure he's super keen to come back. He loves coming here. You can tell. He's always prepared. He's eager and excited. You can just get the vibe off him when he comes through the door. So we're looking at the 10th of February. I did have one question, which was about how it looks.
Sorry, Chair. I've got a question as well. I'm on the list.
You're on the list. Okay, go on.
Sorry, Chair. Just on the available practices in the county, so there's 10. Is there a requirement for the Narren Health Board to provide per head? Is there a per head ratio of? So there's 94,000. Residents in Monmouthshire, so even I can work that out, 9,400 per practice. Is that an average? Can we compare that against other health boards as well?
So our allocation that comes into the health boards is associated to our population base for NHS dental services. I can certainly bring the breakdown of that back to. I'll put it in the briefing paper that I'll submit, so we'll be able to see that in comparison to. I don't know if we'll have the data comparison to other health boards, but I'm sure we'll be able to pull that to be able to give you that comparison as well.
Thanks, Lloyd.
No, thank you.
Over to you, Chair.
That's kind of you. Thank you. Is there anybody else out there, anywhere, that's got a question? If not, no. Well, all right. Can I have a question? So effectively, my question is first of all how does homeless? We talked about homelessness and then trying to facilitate the needs of homeless people. What does that actually look like? And if someone presents themselves as homeless, what kind of interaction? And maybe this one might include then Ian's answer into this. He may understand this. Is how does that look? So they present themselves as homeless. They come to the local authority. They need to have some form of accommodation, and there might be multiple reasons for this, but we're not getting to that. If they present themselves as homeless, how do you pick up on that? Where do you get your, where do you jump into this equation? And is it through the NHS? They present themselves as the GP? Is it through housing? What is it?
So it's a combination of all, really. So we do have a health inclusion service within Iron Bevan University Health Board who works closely with those socially vulnerable groups. So we would get information, access and details from those groups who would then signpost to the relevant areas or flag, for example, to our community dental service to say, we've got X population here, can you provide a domiciliary care service or provide a drop-in centre or whatever it might be in terms of the management of dental service particularly, but also the wider areas. Because of the Integrated Service Partnership Board that there's 5 Integrated Service Partnership Boards across Gwent, one of which is the Monmouthshire one, and we have representatives for all areas of health, but also local authority who've joined there. So if there are particular concerns like socially vulnerable patient groups, that gets flagged there for us to pick up there as well. So there's a number of different sources that we actively try and protect.
Thanks, Lou. You've covered that off. But so for example, in Chepstow, have we got any data, for example, about the, obviously it's more visible these days, unfortunately. 15 years ago, people would be genuinely surprised to see anybody homeless in the county. Now there are a number of people presenting themselves something that it's a very sad situation. So I'd like to think that we, under these circumstances, this administration will be putting pressure on you guys to ensure that we create a better safety net. So where my question is going is how many are there, and have you seen an increase in that trend? Are people coming in from England? Are they people from Wales? Where are they from?
So we do have some data coming in, which comes into our health inclusion service. I don't have the data to hand to be able to tell you the levels. There is an increasing picture.
But we could get that data.
Yeah, and I'm happy to share that as well.
All right, thank you. Right, so finish this meeting again. Rachel, Lloyd, thank you so much for coming along. Sorry, we almost got locked at the meeting earlier, but we made it in, didn't we? I'd like to thank all our guests for coming along. Louise, you've been a fantastic substitute. You may want to come out, so we're going to invite Lloyd, assuming he wants to come again on the 10th of February. You're more than welcome to come along as a guest and follow up on that and maybe get some answers to your questions, Louise. Emma and Peter, thank you very much for coming along, and thank you to all the committee for your patience with, it's been a long meeting. We're going to let you go now. Thank you very much. And we're going to move on to the next item on the agenda. Ian, thank you as well for coming along. Excellent. Number 5 on the agenda, we've got the Public Services Scrutiny Committee Forward Working Programme and Action List. Now, we had a little bit of a conversation about this. Some of you may want to, at the end of the meeting, look at this more broader. Hazel, would you like to just update us on this?
Thanks, Chair. I think if you are inviting Lloyd and Rachel to return in February, you might want to consider whether you want to talk to the Integrated Strategic Partnership Board at some point, because, we need to consider whether dentistry registers with them. So that could be something, because they might have views of what they deliver and, how the flow of funding is directed as well. So that might be a potential line of inquiry for the future on dentistry. In terms of other items on the work programme, I'm trying to organise, I'm trying to organise a workshop for you with the police on county lines, but that would have to be like a non-live streamed sort of session, and I suggest we would invite all members to that. And I think, Chair, you've also suggested to me that you'd like to look at drug-related deaths in Monmouthshire and also community policing, perhaps.
So in pre-meeting, we had a discussion, and we meeting before about the Anara Bever's kind of concern about the increase in drug-related deaths across Gwent. So there's been, you don't have to go far to find that there's been a fair amount of publicity about that, but also the element of synthetics in drugs. Now, whether that ties in with county lines, I guess it will be really up to the committee to establish whether or not they want to look at that as well. I would like that. There's not often I ask for stuff to come forward. You mostly set the agenda, but I would like that included. If members are happy with that proposal, then that's absolutely that would be fantastic. Hazel, is there anything else?
Not at this stage.
No? Okay. Is everybody else? Is anybody else got any views, ideas, concepts? Jill?
I'm just interested in the Vouda SV, whether we can get any updates. Particularly, we've had some scrutiny meetings recently about Prevent, and also I've been reading about the increase in misogyny in schools and how that is affecting.
Okay. Well, it is on
misogyny in schools, and whether we can get them to come earlier and talk to us about, the Andrew Tate effect and other things that happen in the schools that are increasing negative behaviour towards females.
I mean, it's on a theme. It's just not on a theme. It's a specific issue. You're absolutely right. And the broader issue is about discrimination in school and the reporting of that, particularly when we've kind of lost our police liaison officers. But it is on the list, and we will be, we're in the process of inviting them, Joe. So be rest assured that will take place. I can't tell you specifically when, because people don't have to come here. We invite them. It's entirely up to them. But I'm no doubt you'll follow up on that. Are there any other requests, any other, anything else that people want? Is there anything else anybody else wants to bring up?
Chair?
Yeah, Mary.
I was just thinking, with the sort of environment, is it something we can discuss on how effective we are in sort of bringing our carbon footprint down? Is that something that's a big,
you need to be more specific about that.
Okay, right.
So where do you start with that?
I know.
Why don't we're going to wait to the end of the meeting offline, yeah? We're going to have, So
is that meeting?
If we need to update, no, it's not. There is a separate one where so we can bring our concepts in about, you know, the broader issues and whether or not we're, you know, what relationship we have with other public bodies at the end of it. So moving on then, we've got the Cabinet and Council Work Planner. Just for noting that, yeah, okay. And then number 7, to confirm the minutes of the special meeting held on the 25th of July 24. Have we got someone to second that? Have we got anybody who was witness to those, who's prepared to acknowledge that they were want to confirm those minutes? And
yeah, I'll second that.
Yeah,
yeah, I'll second that.
All right, Dale. Yeah, Jill. Fantastic. Okay. And then yet to note the date of the next meeting, which is on the 9th of December. Is everybody happy with that? Yeah? Yes? Yeah? You just nod your head, thumbs up. Yeah, yeah.
It's in there.
Okay, fantastic. So bearing in mind there will be another follow-up meeting. We're going to close the meeting now, guys, all right? So, you know, formally, thank you for attending, everybody. Francis, are you still with us, Francis?
Yeah, are you still with us? Yes, of course I'm still with you. No, sorry, I'm going to have to go. But I did say my thing about so it's not very clear there, but, you know, the point is about the parameters of what practices stroke the health board can change, what their process is, how we can influence that process, and also there's the wider part. He said about the sustainability board as well, didn't he, Lloyd? So anyway, and also, did you not say, or did Hazel say this, that we were having a session around flooding, flood risk, climate, flood? I'm not sure.
Yeah, I think the chair wanted to finish the stream and then have a discussion with the committee about some of the items on the work programme.
Okay, sorry. Yeah, I've got to dash, but I put that in the chat like you said. So
okay, thank you. Look, thank you all for attending, and I'll see you in December. No doubt you'll be full of Christmas cheer by then. Okay, thank you all.
Thanks, Chair.